All right, good afternoon, everyone. I want to welcome you to the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So I want to thank you for muting your microphone once the presentation begins for Zoom participants, being attentive to the presenter and engaged in the session, and completing and submitting a session evaluation form. Next slide, please. There we go. Okay. Here's the activity code for the CME credit. So I'm just going to leave this up on the screen for a couple seconds. So don't forget to register your attendance and claim credit. Slow it a little bit. All right, next slide. Is it going? Next slide, please. Oh, okay. Okay. All right. Little slow on my end. Okay, so here's the how to get the credit via text. Leave that up for a second or two. Okay. The activity code for today is 100907787. Okay, next slide. That is, sorry, my computer's being a little slow. Okay, CME transcripts. Here's more information. I'll just leave this up for a couple more seconds. All right, next slide. And if you need any other information, just feel free to message me through Zoom and I can get this for you. And there's more information about AAFP. Right, next slide. And here is information on the Family and Communication Medicine Grand Rounds. All right, sorry about that. I'm back. I'm obviously downtown. Can you tell by the internet? There's more information about the Grand Rounds. Next slide. And here's the conflict of interest statement. Bridget Murphy has no financial relationships with eligible companies to disclose. So with that, I'm going to hand this over to Bridget Murphy, and she's going to begin her presentation. Thank you so much.
Hi, everyone. Thank you for coming today. Like Erin said, my name is Bridget. I am going to be presenting today on pediatric medical trauma, recognizing and treating in primary care. So I am currently the psychology intern working at the Family Health Clinic. And so I'm going to be presenting today about trauma. So by the end of this presentation, I'm hoping that people will be able to recognize the difference between trauma symptoms and PTSD, as well as what those symptoms can look like in all the different varying ways. I'd also like participants to know the definition and prevalence of medical trauma and the impact that it can have on children and parents. And then my third objective is to learn to apply different levels of interventions for pediatric medical trauma. And so an outline of what that'll look like. First, I'm going to talk about adverse childhood experiences, then move into how we define post-traumatic stress disorder. And then for the third part, getting into some specifics about medical trauma. So I'm going to have some time for questions in the middle before moving into the intervention piece. And then we'll have time for questions at the end as well. So starting off with our adverse childhood experiences, or ACEs as they're called, I'm sure this is something that a lot of people have heard of before. So essentially they are potentially traumatic events that happen during childhood, so between the ages of 0 and 17. And there are a lot of different examples of ACEs, like separation from parents, exposure to violence, things like that. And the reason why we want to make sure that we're paying attention to ACEs is that ACEs are linked to chronic health problems. So as you can see in the diagram there, we have issues with mental health, substance use, as well as education, job opportunities, and earning potential. So all of these things have been found to be connected to adverse childhood experiences. And so as health professionals, we want to make sure that we are paying attention to these experiences that can have impacts on the health things that we are interested in. And so moving into PTSD. So the reason I wanted to start with ACEs is that we can have a lot of different reactions to stress, and not all of them are going to mean that somebody meets criteria for PTSD. So we want to be looking for both reactions to stress, as well as potentially clinical levels of PTSD. And so starting off with our criteria, you'll see there at the top that this is for ages 6+. So once I go through these, I'll go through our differences in criteria for our children under 6. So starting off with our criterion A, and this is from the DSM-5, the Diagnostic and Statistical Manual that we use to diagnose our psychiatric conditions. The first one is going to be exposure to actual or threatened death, serious injury, or sexual violence, either direct experience, witnessing, or learning about. And so this criterion is really important because this is what sets somebody up for the potential to develop PTSD. And then as a result of the exposure to that event, we would want to see for this diagnosis one or more intrusion symptoms. So this will be our flashbacks, nightmares, recurrent or intrusive memories associated with the event. And this can look different for kids versus adults, and I'll go through what that might look like for kids in a bit. Then we have C, our persistent avoidance of stimuli associated with the traumatic events. So beginning after the traumatic event has occurred. Then we have negative alterations in cognition and mood associated with the events beginning or worsening after the event has occurred. And when we look at this criterion, we think about negative thoughts about yourself, about other people, and about the world. And it can look like a number of different emotions. So fear, sadness, guilt, anger, those are common ones, but it's not just one emotion that we're looking for here. Criterion E, we have marked alterations in arousal and reactivity associated with the events beginning or worsening after the traumatic event has occurred. And we call this hyperarousal. It's present before the trauma. What we would look for then is a worsening after the traumatic event. So then we have a disturbance for greater than 1 month. Typically, it's expected that most people who go through a traumatic event will experience some constellation of these effects within the period following the traumatic event. For PTSD, we're looking for symptoms that are lasting greater than 1 month. Also causing clinical distress and impairment, and it's not attributable to the effects of another substance or a medical condition. So that's going to be our general criteria for PTSD for folks over the age of 6. And I hinted at this earlier, but now we have our re-experiencing for children specifically. So for children, we might have that re-experiencing show up in their play. So this could be play that has to do with themes of the trauma or expressing the traumatic events themselves. And so that's something to look out for when you're assessing for PTSD for kids. What does their play look like if we're missing that re-experiencing symptom? Next, nightmares can be frightening dreams without recognizable content. So sometimes children don't have the same kind of words for things to describe their nightmares or be able to really pinpoint what it is. But again, nightmares starting or increasing or worsening after the traumatic event. And then third, in children, trauma-specific reenactment can occur during play. So that's something to keep in mind as you assess kiddos for PTSD. Then we have our criteria for children under 6. So these look similar, but there are some important differences that I've highlighted here. So again, we have our exposure to actual or threatened death, serious injury, or sexual violence. And that should say in direct experiencing, witnessing, or hearing about. One or more intrusion symptoms. So again, we have our flashbacks, nightmares, and intrusive memories in those same alterations. So it could show up in play, and nightmares don't need to specifically be identifiable about the trauma. It could be frightening nightmares. And then C is where we see a difference. So for kids over 6 and adults, we would want to see avoidance and negative alterations in cognition and mood. For kids under 6, we would only need one of those symptoms to be present. So either avoidance, negative alterations in cognition or mood, or both. So the bar isn't as high for kiddos under 6. Then we have our alterations in arousal and reactivity. And the DSM makes a note for this criterion that a sign of alteration in arousal and reactivity in young children could include extreme temper tantrums. And so again, when you're assessing, you want to take that into consideration when you are assessing for those alterations. Duration more than 1 month, clinically significant distress or impairment. And here they expand this definition a little bit more to include relationships with siblings, peers, and other caregivers, or with school behavior, because those are going to be the domains of interest in terms of functioning for our kiddos of this age. And then the last one is always going to be, it's not attributable to some other substance or medication. And so these are our criteria for PTSD. And I just want to note, bringing back my earlier point, that when we think about post-traumatic stress versus post-traumatic stress disorder, those rates are different. So we see a lot higher rates of post-traumatic stress symptoms and lower rates of post-traumatic stress disorder. So when you're assessing, make sure that your patients are meeting all of these criteria if you're going to give them a diagnosis of PTSD. If they're experiencing some symptoms but not meeting that bar for PTSD, they may have an unspecified trauma and stressor related disorder. Still might need some treatment or attention, but it doesn't necessarily mean that they have PTSD. And so I have here a little activity with some participation. So if you either want to put in the chat or unmute, I have some case examples here. And I want you to think about what are your differentials for a child that presents with this set of symptoms. So the first one, a child presents with negative thoughts about themselves, others, in the world, decreased interest in activities, and sleep disturbance. What might our differentials be for a child with those symptoms? Depression. Yep. So we got a couple answers for depression. And yeah, so those are going to be symptoms of depression, right? And we have separation anxiety and PTSD. And that's kind of getting at one of my main takeaways here is that these symptoms are very typical of depression, and they are also ones that meet criteria for PTSD, or fit criteria for PTSD. The next one is going to be a child presents with school avoidance and increased safety behaviors. So checking in with parents, separation anxiety. Okay, anyone else? Yeah, so anxiety disorders, right? That avoidance piece is pretty typical for anxiety. Those safety seeking behaviors also typical for anxiety, but it also might fit our hyperarousal or our increased reactivity, as well as our avoidance piece there. And the last one, a teen. What? Diagnoses for this teen. ADHD, mania, depression, ADHD, depression. Yep, exactly. And so while each of these kids looks differently, presents differently, and they have symptoms of some of these other disorders, they're also exhibiting symptoms of PTSD. So we have our alterations to mood and cognitions, we have our differences to arousal and reactivity, avoidance, all of those things could potentially be our depression, anxiety, ADHD. It could also potentially be trauma. And so when we're assessing, we also want to make sure if we're seeing trauma symptoms, we are assessing if there's a criterion A trauma there that could be driving some of these symptoms that we're seeing. So thank you for participation in my little activity. So now we're going to move into our medical trauma definition specifically. And so the symptoms look the same as what I've been talking through, but I did want to highlight what criterion A could look like in a medical context. And so remember, criterion A is the trauma. So this could be pain, it could be injury, serious illness, medical procedures, or an invasive or frightening treatment experience in a medical setting. And so thinking about the history of pediatric medical trauma, we were first started looking at this in the 1980s and looking at the effect that cancer could have on children and families. And so looking at post-traumatic stress symptoms in both children and parents parents of children who were going through cancer treatment. And so that's where we started. And the field since then has expanded to look at medical trauma in a variety of different medical settings. And looking at rates and prevalence, the Children's Hospital of Philadelphia has done a lot of work with pediatric medical trauma. And so a lot of this foundational research has come out of that institution, as well as the next couple graphs I'm going to be going over. But they found that the rate of significant pediatric medical traumatic stress was approximately 30% across pediatric medical populations. And so you can see that graph there. So we have children on the left, parents on the right, and you'll notice that there are different rates of post-traumatic stress in children than in parents for these different disorders there. So we have cancer, injury, cardiac transplant, and then the PICU for the parents. And one thing I wanted to again point out here is that when we look at rates of post-traumatic stress versus post-traumatic stress disorder due to medical trauma, the rates of post-traumatic stress symptoms are much higher than the rates of PTSD. And so I found some research with PEDS ICU patients saying that the rates of PTSD were about 5 to 28, whereas the rate of post-traumatic stress symptoms was about 35 to 62. So again, just because parents or children are experiencing post-traumatic stress symptoms does not necessarily mean they have PTSD, and that there are a range of ways that we can treat both the symptoms and the disorder. Okay. So what is most traumatic for our kids and our parents? And so this is interesting because the answers are different. So again, this study comes from Children's Hospital of Philadelphia. And they found that for children, shots and losing their hair were the top two things that were most traumatic for them in terms of their cancer treatment. Whereas for moms, shots and losing hair were coming in at 8 and 10. Whereas for moms, the scariest things are worried about relapse, pain, being scared about death, and the diagnosis being traumatic. And for kiddos, those things were farther down the list in the 7 to 10 range. And so when we are treating kids and families, we want to keep in mind that kids and their parents and their family members may have different parts of the medical experience that are most traumatic for them. And so when we're planning treatment, we want to keep that in mind. Okay. So one final note on the medical trauma definition is that perception of the life threat and the subjective experience or the patient or the parent's appraisal of the severity of the illness or injury leads to greater traumatic reactions. And so this makes it very difficult to figure out who is going to experience post-traumatic stress symptoms from medical trauma just by reading their case record or their medical record or notes from whatever injury or illness that they have, because those objective characteristics are not as predictive of the development of symptoms as the subjective experience of it. So maybe on paper, one kiddo went through something that was much more life-threatening, but the child and their parents didn't really perceive it that way. That child is at lower risk for developing post-traumatic stress symptoms than a child who may have, on paper, went through something less life-threatening, but who experienced it as very scary and very life-threatening. And so that's one of the reasons why we want to make sure people are screening adequately for these types of symptoms, because it's very difficult to look on paper and figure out who is going to develop symptoms or not. Okay, so moving from the definition into some of our risk and protective factors, starting off with our risk factors for children. And so the first one is going to be pre-existing individual or family characteristics. So typically, kids who have an anxious disposition or other kinds of mental health diagnoses are at higher risk for developing post-traumatic stress symptoms, as well as kids who've been through previous traumatic events. And so here we want to call back to our ACEs, right? So a kid who has more of these ACEs is at more risk for developing post-traumatic stress symptoms. Same with family characteristics. So if you have, families who generally run higher with anxiety, then they may have an increased subjective experience of life threat with their medical experiences. So that puts people at risk for developing post-traumatic stress symptoms. The second one is early physiological or psychological response. So when I say early, I mean when they're still in the hospital, or responses happening within hours or days of the traumatic medical event. And then that physiological response. So there's actually research connecting like an elevated heart rate in the emergency department to increased risk for developing post-traumatic stress symptoms. And so if you're a medical professional who's seeing a child and family through the hours and days after the medical event, these are some things to look out for in terms of risk for developing post-traumatic stress symptoms down the line. More risk factors for children, we have aspects of the condition or treatment. So I know that I said that the objective pieces of the experience are not as important as the subjective, and that still holds, but you can sometimes tell by some of the aspects of the condition or treatment how people might perceive those. And so length of hospitalization would be one. Separation from parents, remember thinking back to our ACEs, that's an ACE in itself. An exposure to frightening sights and sounds, and then subjective sense of threat. So that one is always going to be very important, is that child's subjective experience of what is going on. And then lastly, we have our maladaptive coping. And so the two that were identified within this paper were withdrawal and avoidance. And so this was pulling back from their support system and avoiding things, especially when we're thinking about PTSD, reminders of the trauma. And this could look like avoidance of medical treatments, avoidance of going back to the doctor, and things like that. So the aspects of the condition and the response to the treatment and the way that kids cope with it can put them at risk for development of post-traumatic stress symptoms. We also have risk factors for parents. So parent anxiety during treatment. This calls back to the predisposition or pre-existing psychological factors. Then we have the presence and severity of acute traumatic stress symptoms in parents. So if parents are developing symptoms early on, that would be a risk factor. Fearing the child will die. So again, thinking about that subjective life threat, if you're fearing that your child will die, that subjective life threat is likely pretty high. Worrying about relapse. Again, going back to the subjective worry about relapse. And then unexpectedness of the event, illness, hospitalization, or injury. Then, as always, the risk depends on the subjective appraisal of these factors. So for our risk factors, we always have our protective factors. So our protective factors are going to look similar for our children and our parents. The first one is going to be social support. So parents supporting their children, parents having the support network themselves, maybe some other family, friends, local community supports, and so on. Social support is very important, especially when families are going through a crisis. We have age-appropriate social activities. This is going to be for our kids. So as much as you can, keeping them in the activities that they enjoy, not pulling them from the soccer team if we don't have to, letting them be involved as much as they can with other kids their age, doing appropriate activities. This not only keeps them busy and engaged, but it also gives them that social support from their peers. And then, as I mentioned, family support, not just the immediate family support, but also extended family support if that's available and possible. Then we have our healthy coping. So learning how to manage anxiety. Like I said on the previous slide, parent anxiety during treatment is going to be a risk factor. And so teaching parents how to manage anxiety would be a protective factor. Remaining realistic about risk, thinking about how that subjective experience is a big risk factor for the development of post-traumatic stress symptoms. We want to make sure that parents, children, families have a very realistic sense of what the risks are for the medical treatment or the procedure that they're undergoing. And then proactive coping. So thinking back to our risk factor of unexpectedness, being able to cope as much as we can ahead of time, ahead of a procedure, ahead of a treatment, ahead of a hospitalization. The more that children and parents and families are prepared and ready and with their coping skills, the less likely they are to develop those post-traumatic stress symptoms. So being proactive with our coping. So I've said a lot, I've given you a lot of information at this point. Do we have any questions so far about the definition of PTSD, definition of medical trauma in particular, and then our risk and protective factors before I move into talking about treatment? Okay, I don't see anything, so I will just keep going. Again, there'll be more time for questions at the end. So starting off, before we get into treatment, we want to first talk about how do we assess for post-traumatic stress symptoms and PTSD in our kids and families. And there are a number of different options. And I have a resource slide at the end of the presentation that links to some of these here. So research finds that after an injury, screening for acute stress reactions shows the most promise for identifying those at risk of developing PTSD symptoms months later. And so there are a number of different ways that we can do this. The first one would be the acute stress checklist for children. That's 29 items in total. There are also some briefer options that are 3 and 6 items. It is a self-report checklist and it is free to access and use, which is great. Then we have our child trauma screening questionnaire. This is for ages 7 to 16, 10 items, self-report checklist, again, free to access and use. Then we have our screening tool for early predictors of post-traumatic stress disorder, ages 8 to 17. This one's a little bit different because it's 4 items to ask the child, 4 to ask the parent, and then 4 to take from the medical chart. And it's developed to be used in acute care before discharge. It's also free to access and use. And this is something that you want to do before the child leaves your care. And then we have the psychosocial assessment tool. It's a part of a universal approach in preventative care for childhood medical trauma. However, you must request it from the developers. I'll admit I have not requested the full measure, but there's a lot of research out there about it. So if that is something of interest to you, you can request it from the developers and see how you can fit that into your practice. One important note that I have for screening is that if you're going to implement a screening process, you have to have some kind of resource for the child or family if the screen comes back positive. So screening is great, but the point of screening is to identify the kids and families that need more targeted or clinical levels of help. And so we need to make sure that we have some options to give the child and family if they were to screen positive for those post-traumatic stress symptoms, or even risks for developing post-traumatic stress symptoms or PTSD. And luckily, I'm going to be giving you some of those. So we're going to be going into talking about intervention now. So borrowing from our public health folks, we have this prevention pyramid, and it highlights 3 levels of intervention. So this first one is going to be the universal level, where these types of interventions are provided for all the families that we see. Next, we have in the middle there our targeted level. So these are families that are identified at the universal levels, perhaps needing more support. And so they get a little bit higher level of intervention. If that little bit of higher level of intervention is not sufficient, then we have our third level. So these are children and families who are in need of clinical levels of treatment. So the goal is that we're able to catch people and provide them with the correct amount of intervention for the issues that they're dealing with. So starting off with our universal level, again, these are services provided to all children and families, and this can include screening, assessing risk, identifying families that could potentially be needing some targeted or clinical levels of treatment. It also looks like providing psychoeducation about common stress reactions and risk. So what is normal in terms of reacting to this medical event that the child just went through? What might be a sign that the reaction is a bit more severe than what we would expect? And then thinking about how subjective appraisal of risk is going to be either a risk factor or a protective factor, depending on how the family is able to understand the risk. Making sure that they understand the risk is going to be really helpful for them. Third one, providing families with support, both social and emotional. So asking questions about how well connected the family is, who is supporting them, what kind of activities the child is involved with, and how the community around them could potentially help them through this medical event. And then finally, highlighting the child and family's coping skills and strengths. So as you're speaking with the family, if you're noticing that they have a really strong support of each other, really strong community support, if they have skills that they use already to help with anxiety, building on those and really emphasizing and reinforcing their use of those can be really protective. And so these are things that we can do for all families and all children that come through who have experienced a significant medical event. And so if we are able to engage people at that universal level, again, we can target people who are in need of more support than at that base level. And so this moves us up to the targeted level, which includes helping to anticipate challenges, mitigate risk, and enhance coping skills and strengths. And so there are a lot of different ways that we can do this. So having some more appointments with families leading up to a treatment or a procedure, making sure that families are aware of not just the risks of the medical procedure, but also what are the risk factors for developing post-traumatic stress symptoms down the line, and what are some things they can do ahead of time to be ready for that in case it should happen. And then enhancing coping skills and strengths. At this level, there's also a few different targeted brief interventions. I found a few and listed them here. They're for specific medical events. So we have surviving cancer competently, which is intervention for newly diagnosed kids with cancer and their parents. Pro Moms, which is for moms with premature infants. And then the stepped preventative care for injury. So this is a series of assessments to identify people at risk for developing post-traumatic stress symptoms with some brief intervention in between if people are identified as in need. And so this is stuff that can be done not necessarily just by a mental or behavioral health clinician. It's something that we can do in a lot of different settings to help increase families' strengths and preparedness for medical events. And so this brings me to what can we do in primary care. So universal targeted intervention are really well suited for the primary care setting. We are set up well for screening. And if you have access to a behavioral health consultant, we do at where I work, we follow the primary care behavioral health model. And so our BHCs there can help families build specific coping skills and strengthen the coping skills that they already have. There's a focus on population health, so we want to see as many of our families as we can. And it's a setup that we're able to do that. So if you do have BHCs at your clinic or your place, really leaning on them, using them for that targeted level of intervention. And then providing resources and information for parents and children. So I have, like I mentioned, a resource slide at the end of this presentation. The National Child Traumatic Stress Network is an excellent website. They have a lot of different handouts, PDFs, things that you can go through to present to parents and kind of give them some background on what they're going through, and also some future directions for where they can seek help. Similarly, 123 Toolkit also has a very similar function. They have a lot of PDFs and a lot of good information. And then finally, building protective factors. So if we know that social support and building good coping skills are things that can prevent the development of post-traumatic stress symptoms, or if somebody has post-traumatic stress symptoms, prevent the development of PTSD, we can provide families information about those protective factors, help them in their community build some kind of supports, and help them build those coping skills, whether it's some relaxation skills to help with anxiety, whether it's some cognitive behavioral treatment to help with alarming thoughts about the medical treatment, or whatever it might be. Beefing up that social support and building those coping skills are going to increase the protection the family and the child have from developing post-traumatic stress symptoms. And then we have our last level is going to be our clinical level. So these are children and families who need more intensive services than can be provided at the universal and the targeted level. And these are services that do need to be provided by a behavioral health clinician. These services provide psychosocial support as well as evidence-based treatments. So when we're thinking about children, the gold standard for evidence-based treatment for trauma is going to be trauma-focused CBT, or trauma-focused cognitive behavioral therapy. It's about 12 to 16 sessions, pretty big age range. So from about ages 3 to 18, both the parent and the child are involved. Actually, a part of the treatment is teaching the parent parenting skills to help their child through the traumatic event. And then this is available in the community. So with our children in San Antonio, I know people are calling in from elsewhere. There are a number of organizations that provide TFCBT. Unfortunately, at this point, we don't have a primary care adapted trauma-focused CBT. And so we're not able to provide it in the primary care setting, but there are some organizations that are able to provide that service. So at this point, that's all the information I have for you. I have some takeaways on the next slide, but first I want to ask if there are any questions or comments. Okay. I'm not seeing anything. Somebody in the chat, Dr. Aguilar, I have the observation that the way families and therefore children respond to medical issues might be very much governed by familiar and cultural rules. So I was not able to find a lot of information about cultural differences. I imagine, given that there are cultural differences in the way that children and families respond to mental health in general, that would be the case. I'm wondering if anyone has any specific examples or that they've noticed in terms of cultural differences.
Bridget, this is Dr. Hepburn. I've been told, now I don't know if this is valid. Can you hear me okay?
Yeah, I can hear you.
Yeah, like in Japan, historically, sometimes when somebody has a serious diagnosis like cancer, that's actually not confided to the patient. Now, maybe some of you that are more familiar, that I'm dating myself from a couple of years back, but there probably are distinct cultural differences in certain groups. So something to be mindful of.
Mhm. Yeah, absolutely. Especially when we think about social support being such a big protective factor. If you feel as though you're not able to talk to those that you're closest with about the medical event or the diagnosis, that would be cutting off a big protective factor that we would want to build for our patients. So definitely something to keep in mind. And then in the chat, just that there might be a push to to be silent or suffer silently. So kind of similar that that type of approach can be tough for building social support. So thinking about ways that you can help that patient or that family build social support without necessarily bringing in the medical event. So making sure that they're continuing to engage in ways that they feel comfortable.
And I would just offer, Bridget, this is Dr. Hepburn again, be mindful of the extended family too, because there'll be times you might see the parent not wanting the grandparent to know about the child, or so just look at that immediate family and the broader family too. So when you're rendering that care.
Yes, absolutely. Thank you. Thank you for that insight. All right. All right. I don't see any other questions. So I have my main takeaways here. So when we're looking at PTSD in children versus adults, we want to make sure that we're aware of the differences and the different ways that can present in children, including the differential diagnoses. So things that could look like depression, anxiety, ADHD that may actually be attributable to trauma. Pediatric medical trauma is prevalent in children and families. And as practitioners, we can intervene at the universal, targeted, and clinical levels. And so there's a lot that we can do to help these kids and families. And then, as was mentioned in the Q&A, making sure that we're taking into consideration culture and how the family is reacting to the medical event and from their background and experiences. And then here's the resources. I'm not sure what the rules are about sending this out, but feel free to reach out if you would like any of these. These are all hyperlinked, and it has a lot of good information on these websites to give you some more background on pediatric medical trauma. And there's references.
All right, thank you, Bridget. Everyone, if you need anything, just let us know. Other than that, have a good afternoon, okay?
Thank you.
Yeah.